Since you've connected, obviously you know the telephone number and how to get on with our webinar today. Thank you for connecting. Please remember to kindly key asterisk pound to mute and unmute your phone. We do offer CMEs for your presentation today. You're eligible for one CME or CEU via the information here and in the handout, which is posted at envisionnm.org. Today's topic is anxiety in students, signs, symptoms, variety, and impacts. And I'm Dan Rifkin here with
Chris Carrillo. Welcome.
Welcome is right. We're both with Envision, New Mexico, and have been working in school-based health centers in various capacities for a while.
We don't want to say how many years.
As a child and adolescent psychiatrist, I'm a school-based health center provider with much of my time both directly, and I also support school-based health center providers throughout New Mexico and sometimes in adjacent states. So for our webinar today on student anxiety, we would seek to understand the impacts of anxiety on students, identify characteristic signs and symptoms of anxiety in students, recognize the various anxiety disorders in a developmental context, and to describe an anxiety screening tool and an assessment instrument for use in your school-based health center.
And Dan, I'm feeling a little anxious right now because we haven't asked people to identify themselves.
So without further ado, we're going to hold our progress here while we ask you to please identify yourselves.
Don't forget to unmute. So who's calling in today?
I'm Susan Jenks, school nurse for APS Public Schools.
Welcome,
I'm
Susan.
Cindy Brault. Thank you. I'm Cindy Brault. I'm a health assistant for APS Public Schools.
Cindy, what is your last name?
Brault.
Thank you.
Thank you.
I'm Ivan Wong, a graduate of UNM, a physician assistant at a school-based center in Portland, Oregon area.
Welcome, Ivan.
Thank you.
Anybody else on the line?
This is Kate O'Donnell. I'm calling in from the School-Based Health Center State Program Office, also in Portland, Oregon.
Well, welcome.
Yeah, welcome from Portland. So far we've heard from Susan, Ivan, Catherine, and Cindy. Is there anybody else connected with the webinar at this time?
We could do another roll call later
We sure
on.
could. That I would feel comfortable rather than anxious about that.
Okay, Dan.
That would be great. So just to identify the handouts for today's presentation, the PowerPoint slides and our student health questionnaire are posted at our website. And the assessment instrument that we're going to be using will be part of our next webinar coming up just under 2 weeks from now on Monday, December 16th. So in an effort to keep you in a bit of suspense, but not causing you to feel scared, the scared will be part of that presentation. And just to make sure that everybody is familiar with how to access tools at our website, I want to be sure you have the opportunity to
Is it there?
access envisionnm.org. Thanks, Chris. Going to our calendar. And you should, is everybody seeing our website on your screen?
Yes.
Okay.
Yes.
Great.
Yeah, I see it.
You
Yes,
click
I see
on
it.
today's webinar.
Click on the words. Yeah.
Okay. Not only will you see pictures of your presenters, but you'll see the PowerPoint handout. You can click on that and open that way with your Adobe Reader. And you can also receive the Student Health Questionnaire, which we're using as an exemplary 2-item anxiety screen that we'll be getting to. But Chris, I'm going to get back to the PowerPoint. I'm starting to feel anxious about spending more time on the website
Okay.
at this point.
So, what is anxiety?
That's a good question, Chris.
So I think most of us probably understand anxiety to be, a subjective sense of worry, apprehension, fear, and distress. And, our subjective experience of anxiety typically has two components, physical sensations as well as psychological components of nervousness and fear. So, just a reminder, everybody experiences anxiety. It's a natural and important emotion. But sometimes anxiety becomes exaggerated and unhealthy. But normal anxiety, I think, is a physiological preparedness to a potential threat. That's the kind of normal. And pathological anxiety is really an impaired ability to respond to the environment or to respond to that threat.
And our perspective today, when talking about anxiety, is, as usual, a biopsychosocial view and approach, considering genetic and physiologic correlates of anxiety, along with psychological aspects such as what Chris just explained that can correlate with experiences that one has in their life and the way they think and feel about it, as well as social and environmental correlates to anxiety. Well, what is the prevalence of anxiety?
So I don't know that I actually realized that anxiety symptoms and disorders are the #1 health problem in America. I don't think I knew that.
And that they range from generalized anxiety disorder, which may be the most prevalent of the anxiety disorders, to more difficult and debilitating disorders such as panic disorder and post-traumatic stress disorder.
So not only are they the #1 health problem, they're also the most common childhood psychiatric disorder.
Which really surprised Chris and me insofar as we had thought that depression was the most common childhood behavioral health problem.
So we'll look at the impact of anxiety on youth, looking at the impacts on their cognition, their thinking and decision-making abilities and perceptions of the environment, concentration, learning, memory, those kinds of things. We'll look at the physical impact of anxiety on youth, and we'll look at the relational impact in a social setting, how anxiety affects anxious teenagers.
And we're also going to take a look at what are the causes of anxiety. This can include psychological aspects of the etiology. Anxiety can result when a combination of increased internal and external stressors overwhelm one's normal coping abilities, or when one's ability to cope normally is lessened for some reason, such as through psychodynamic, behavioral, and spiritual factors. And I think this combination of internal and external stressors is important, with the internal really connoting the psychological aspect and how, again, one thinks and feels about the situation they're in and copes with handling the external stressors.
Mm-hmm.
Then there are the genetic etiologic factors.
So 50% of patients with panic disorder have at least one relative affected with an anxiety disorder. So it can show up, it can repeatedly show up in families. There's a higher chance of an anxiety disorder in the parents, children, and siblings of a person with an anxiety disorder than in the relatives of somebody without. So there's a strong genetic component.
And there are biochemical etiologic factors. As evidence exists that supports the involvement of at least 3 neurotransmitter systems that are involved with norepinephrine, firstly, secondly, serotonin, and the third one being GABA. And correlated with this, it's at least worth brief mention that many of the psychopharmacotherapeutic agents, the psychotropic medications, if you will, act on these 3 systems. For students experiencing excessive anxiety, there appears to be dysregulation of the noradrenergic and serotonergic neural systems, which are complexly interrelated in the brain. And therefore, again, psychotropic medications modulate these systems. We mentioned earlier that the biopsychosocial model would be drawn upon in our perspective, and that would be our view of these disorders. And it's very helpful in explaining the etiology as well, insofar as it really encourages us to identify the biologic aspects, the psychologic aspects, and the social and environmental factors. The biopsychosocial model, incidentally, was developed by George Engel in the 1970s. He continued to publish about it into the 1980s and even later.
Okay, I have some down there. Yeah.
Initially, to explain heart disease and other medical illnesses. It's very applicable to asthma, for example. It also explains psychiatric disorders, including anxiety. Incidentally, George Engel was an internist who later became a psychiatrist.
So when we think about anxiety disorders, we kind of hold these thoughts in mind that diagnosis of normal versus abnormal anxiety really depends largely upon the degree of distress and on its effect on a student's functioning. So anxiety disorders have distressing and impairing severity. And so when you're looking at a student that you consider when you're thinking that might be suffering from some kind of anxiety disorder, you really need to gauge the degree of abnormality within the context of their age and their developmental level. And we'll be kind of going through some of the disorders, thinking about them developmentally.
That's right. And we'll take a developmental view of looking at the various anxiety disorders. And before we do, let's review aspects of what constitutes a psychiatric disorder versus a problem or uncomfortable condition. Psychiatric disorders are severe and they are pervasive. so that they can be experienced by a person in a severe way most everywhere they go. They persist or recur across time, cause functional impairment in students. That's often reflected academically, but also in relationships. And a psychiatric disorder has the biological, psychological, and social origins that we've been talking about.
So Dan, let me ask a question about the pervasiveness.
Yes.
So when we think about pervasiveness of any kind of a psychiatric disorder, we're thinking about, so it crosses environments. So a child
That's right.
who's experiencing anxiety at home will also experience it at school. But it could look a little different, couldn't it?
It could.
Okay. So
It could.
it's still present in different environments, and it could change depending on the social context.
Indeed. For example, a child who is having severe anxiety as a result of trauma that is ongoing in the home environment could appear different at home than at school.
Yeah. Okay.
And the student who is having social phobia, we'll talk about in just a moment as an example. When a student has a specific phobia, there's a persistent and significant fear of a specific situation or object that exposure to immediately provokes severe anxiety, and the distress significantly interferes with a person's normal functioning or routine. So in a school situation, a young child who for some reason has a terrible fear of rodents, okay, we could make up a scenario. Say the child had a very bad experience when they were very young with rodents in their home or community environment. Now they live in an environment where there's not an exposure to rodents, so that they do not experience this persistent and significant fear because they don't have the exposure. But then they go to school, and in their elementary school classes, typical of many third and fourth grade classes, may have a rodent or a hamster in a cage in the back of the classroom. And when there is exposure to that stimulus, the child experiences severe anxiety. Here they're experiencing it at school, whereas they're not experiencing it at home. And it's at school that it could really interfere with the person's normal functioning or routine. So here it would not seem to have the pervasiveness across settings, but it would recur at school and not at home.
And have we started with specific phobias because these tend to be more common in younger children?
That's right. That's right. And it's really setting up a perspective that I'll forward to, having to do with a structure for looking at these anxiety disorders in youth that really takes a developmental view in its sequence up through post-traumatic stress disorder. Okay. Specific phobia tends to emerge in younger children, followed by separation anxiety disorder and selective mutism also in younger children. Because very young children, even before, when they're pre-verbal, could develop a specific phobia. But they usually don't develop selective mutism until language is acquired and mastered, and there are opportunities for leaving home, such as going to preschool. Then generalized anxiety disorder follows, and obsessive-compulsive disorder, which can develop in young children. Followed by social phobia, panic disorder, and PTSD. So going back to our beginning of our sequence, We just discovered specific phobia, or just discussed, and now we'll continue on with separation anxiety disorder, which results when there's recurrent excessive anxiety, fear, or worry concerning separation from home and or major attachment figures. Becomes often manifested as anxiety disorders are in younger children through symptoms of digestive tract upset such as stomach ache and by headaches. This is a major cause of school refusal. However, there are other conditions that cause school refusals, such as other anxiety disorders, depression, and psychosis can cause school refusal, with the DDX here indicating it being of differential diagnostic significance.
So you might see some separation anxiety in say, kindergartners or first graders as they're getting used to being at school.
That's right. That's right. And it would really be exemplary of the difficulty coping with separation from home.
Mm-hmm. So it could develop, but it's a typical developmental reaction to separation, but that's not the disorder.
Actually, it is a disorder.
Okay.
When it becomes severe. So, for example, the child who separates from home initially to go to preschool and is having difficulty making that adjustment,
right.
That could be normal childhood experience. Every child finds it stressful to separate from home initially. But if the difficulties with separation continue, then it becomes more of a clinical concern. Mm-hmm. And it could be part of an adjustment condition, adjustment disorder with anxiety, because of a severe psychosocial stressor going on at home, which could even be that there is a home construction or remodeling project going on, that the child is experiencing a disruption of their home environment, and that they become worried and scared about what's going to be changed or rearranged when they're away from home. We would expect that a child would adjust to that. But when initially not adjusting to it, it could become an adjustment disorder. But if that continues over time, then it could be a separation anxiety disorder. And it often has to do with the significance of the major attachment figures, and often having to do with worries about what might happen to the attachment relationship or the attachment figure themselves. So, for example, if an attachment figure has been harmed at home in the past, the child could have difficulty separating from home because of the worry and fear about what could be happening to that major attachment figure at home. And unfortunately, that's often what we see in students we see in school-based health center who have developed separation anxiety disorder.
Are there any questions or comments thus far? Okay.
Well, what I begin to feel a little anxious about is that we've covered a fair amount of information so far, and I think I speak for Chris as well in thinking that there may be some questions at this point. Did I sense somebody unmuting their phone?
Don't want to cut anybody off.
Yep, so this is Ivan. I'd have a question, or it might not be in the scope of this presentation, but in terms of reactive attachment disorder and how this might fit in with anxiety disorders.
Yes.
This being an area with quite a few refugees, I'm anticipating seeing a patient with those kinds of concerns at some point, and wonder if you could speak to that maybe at the end of the presentation.
You know, I think a good place to do that would be when we talk about the DSM-IV, as well as here when talking about separation anxiety disorder, because of it having to do with anxiety, fear, and worry about the separation from major attachment figures.
Okay.
There's a greater, go ahead.
No, I was just agreeing. That sounds good.
Well, when we think about attachment, we know that there is a healthy attachment that all of us healthy parents who think about attachment and healthy child development want for our kids and for our students. Mm-hmm. That will allow a child to cope with the kinds of changes that can occur at home and in their lives, such as been mentioned a little while ago. But children whose attachment has become disrupted are more likely going to develop various degrees of anxiety in their attachment relationships, such as insecure attachment. And a child who has insecure attachments is going to be more likely to develop separation anxiety disorder.
Makes sense.
And the correlation to the DSM-IV actually has to do with the new categorization or schema in the DSM-V clumps adjustment disorders and adjustment disorders and reactive attachment disorders together.
Okay.
Ready for the next slide?
Great. In generalized anxiety disorder, there is difficulty controlling excessive worry, apprehension, and anxiety about numerous events or activities. And that can include school performance, social interactions, but not only about social anxiety, but about academic performance, job interviews, numerous situations. That it lasts for a significant period of time. Symptoms can include restlessness, irritability, concentration difficulty, insomnia, fatigue, and muscle tension. And altogether, those will really look like like the constellation of an anxiety disorder. However, the restlessness of generalized anxiety disorder, as well as other anxiety disorders, sometimes can cause children, especially younger children, to present like they have ADHD, to have the irritability typical of childhood depression, the concentration difficulties typical of ADHD, inattentive type or combined type. The insomnia of an anxiety disorder is usually at the time of going to sleep or delayed onset of sleep, increased sleep latency, whatever language is used. That's more typical of an anxiety disorder versus depression causes insomnia early in the morning and or with intermittent awakenings. Yeah. Generalized anxiety disorder can also cause numerous somatic complaints in children, again, headaches and stomach aches.
And you see a lot of that in school-based health centers.
A lot of it. Now, obsessive-compulsive disorder is more rare than one might think, especially nowadays when, quote, OCD, unquote, is really become part of usual school and other institutional and social lexicon.
Right. It's like you got one all OCD on me, Dan.
Yeah, that's right. As I'll even hear my own children coming home from middle school saying that somebody's OCD or being OCD. And it's also over-identified in clinical settings. Some of our therapists will identify concerns about a youth possibly having OCD because they will get up and need to clean up their room a number of times. Well, that could be anxiety-driven, rather compulsive behavior that really may not fit with OCD itself, because OCD has persistent obsessions, which are intrusive, unwanted thoughts, images, urges, ideas, and or compulsions, which are an intense, uncontrollable, repetitive, or mental act related to the obsessions. These are noted to be unreasonable and excessive, and they have an ego-dystonic quality about them. That is, not seeming to be driven from within, such as in the case of an ego-syntonic experience, but to be driven by something that is intrusive or unwanted. So for the student who is repeatedly cleaning their room, but they're experiencing anxiety from within, that is not manifestation of OCD. Mm-hmm. Whereas a student who is having some kind of intrusive or unpleasant thought, and the way they can get that thought to go away is to get up and sweep their floor, that would be more typical of OCD.
And isn't there kind of a bargaining kind of quality to it, Dan? In my experience, some people will have an obsession that something bad will happen to somebody they love, and in order to have that not happen, they have to do the compulsive behavior, like never stepping on a crack, for instance. That's a pretty classic one.
So that's the bargain?
That's the bargain.
Okay, I won't step on
a crack, and therefore...
That can be subjectively experienced by the individual. That's right.
Social phobia.
Social phobia involves a persistent and significant fear of social and or performance situations due to a continual fear of scrutiny by others. So again, it can be performance, a musical performance. It could be getting up in front of a classroom and giving a presentation. The exposure to the feared situation almost always provokes anxiety, and there can be tremendous anticipatory anxiety of the feared event. Social and or performance situations are avoided, or they're endured with intense anxiety.
So is this something a student could develop who's been getting bullied?
Sure it could. Sure, they could be very afraid of interactions, social interactions with perpetrators, insofar as those interactions become repetitive and there's usually harm intended by those situations. That can really cause anxiety for students. In panic disorder, there is recurrent, unexpected, and untriggered panic attacks, with inter-episode worry about having more attacks. So again, these are unexpected, they're untriggered. The panic can prevail anywhere. And in between those panic attacks, there can be a lot of worry about further anxiety and further panic attacks, which will beget more anxiety and more panic attacks.
Well, and it really impairs functioning if you don't.
It really does.
So, say if you had a panic attack in a particular location, you won't want to go back to that location.
Well, such as occurs with agoraphobia, the fear of crowded places and open spaces. So, stereotypically, shopping malls are difficult to go to, but an individual could have trouble leaving home because they anticipate so much difficulty and are really impaired by that.
And did you know agora is the Greek word for marketplace?
Well, now that's quite a correlation there, Chris. That's
Fear of the marketplace.
That's right.
So I'm glad you mentioned them all.
I'm glad you mentioned them all too, Chris. Well, post-traumatic stress disorder, or PTSD, has become very common terminology in our society, and perhaps more in some cultures than others within our society. And a hallmark feature of PTSD is the re-experiencing of past traumas through repeated behaviors such as a bully on campus, emotions, bodily sensations. So here I'm gonna delineate something. The re-experiencing of the past traumas can be triggered by the repeated behaviors of somebody else, but can cause repeated behaviors in the individual, emotions, bodily sensations, flashbacks, intrusive recollections, nightmares, other bad dreams. They often include illusions, hallucinations, dissociative episodes, and triggered panic attacks. So these panic attacks are triggered by the re-experiencing rather than the untriggered panic attacks characteristic of panic disorder.
So exposure to the stimulus.
That's right, will trigger panic attacks. There's increased arousal symptoms as noted in irritability, insomnia, concentration difficulties, anger outbursts, which are reactive to the PTSD. Hypervigilance, in other words, needing to be looking around and making sure things are safe, and an exaggerated startle. Other features include avoiding the post-traumatic stimulus and numbing and a sense of foreshortened future. So students with PTSD may think that they're not going to make it until they're not going to live beyond their 22nd birthday or 18th birthday. So the various disorders that have just been surveyed, again, come in the sequence that is seen in this scheme, at least the first several disorders in this scheme. And this is the listing of youth anxiety disorders in the DSM-IV. And I'd want to clarify that these are not specific to youth, but that youth can have any of these anxiety disorders. Now in the DSM-IV, separation anxiety disorder and selective mutism are purposely shown here as number 2, and they are in a separate section of the DSM-IV, separate from the other anxiety disorders listed here. This is a grouping that is under the child and adolescent disorders.
In the DSM-IV.
In the DSM-IV. Disorders usually first diagnosed in infancy, childhood, or adolescence. And there's a residual section starting with the word other disorders that includes separation anxiety disorder and selective mutism. And I'm pointing this out right now on a chart from the DSM-IV classification. Whereas the other anxiety disorders can also be present in adults. Now in the new scheme in the DSM-V, we're going to be looking at how the youth anxiety disorders are categorized in the new DSM-V. They're in 3 locations as follows. There's the anxiety disorders categorization that includes what we just went over: specific phobia, separation anxiety disorder, and selective mutism are now in the anxiety disorders category. Social anxiety disorder is the new name for social phobia. And panic disorder is now separated from agoraphobia. In the DSM-IV, panic disorder occurred with and without agoraphobia. So there'd be panic disorder with agoraphobia, panic disorder without agoraphobia. In the new DSM-V, there's panic disorder and there's agoraphobia. They can occur together, they can occur separately. Generalized anxiety disorder, and there's new terminology for what was in the DSM-IV as anxiety disorder not otherwise specified, which is a subsyndromal condition that doesn't meet any of the other conditions. There's now other specified or unspecified anxiety disorder. Both are subsyndromal, that is, they do not meet the diagnostic criteria for the other disorders, and the unspecified has insufficient information to describe the features, whereas in the specified version, one documents what the features are. In both of these schemes, there also is a substance or medication-induced anxiety disorder and a disorder due to a medical condition. The terminology varies a little bit. Well, what about OCD and PTSD in the DSM-V? Well, OCD is now in a new chapter referred to as Obsessive-Compulsive and Related Disorders that actually includes impulsive disorders.
Okay.
Impulsive behavioral disorders. Whereas PTSD and acute stress disorder are in a new chapter, trauma and stressor-related disorders. Well, what can help us identify student anxiety disorders in school-based health centers? There's the screening tool, which is embedded in the student health questionnaire. And there's the anxiety instrument, the assessment instrument for anxiety. Well, when screening for student anxiety in school-based health centers, all students in the school-based health centers here in New Mexico, at least those that are funded by the Department of Health, receive the student health questionnaire that has the two items: do you often worry or feel like something bad might happen, which really screens for the psychological aspects of anxiety. And the second item, are you often tense, stressed out, or have trouble or difficulty relaxing, which screens for the physical aspects of anxiety. These are in the high school and middle school versions of the student health questionnaire. They're yes/no questions, and a yes answer to either of them is interpreted as a positive screen. Now, very quickly, having mentioned the student health questionnaire as being one of our handouts for today, I want to point out that here in the high school version,
Number 18 and 19.
Number 18 and 19 are the two items that were just described as forming the two-item anxiety screen embedded in the student health questionnaire.
Thanks for pointing that out.
I thought it would be worth pointing to. Well, what do we do when we have a positive screen? Then we need to, in that case, an assessment is indicated by the positive screen. And it's important to note that to screen is not to assess, and a screening tool is different than an assessment instrument. So what do we do to assess? Well, when we have a positive screen, we administer an assessment instrument for anxiety, referred to as the SCARED. Just like we administer the PHQ-9 modified for teens when there is a positive screen for depression, known as the PHQ-2. Because screening will identify the youth at risk for anxiety disorders and their psychiatric comorbidity. And the assessment really begins with the assessment instrument, the SCARED being a longer, more in-depth instrument than our brief screen. A comprehensive assessment would be the next step performed when indicated by the assessment instrument. This involves a sequential approach using short steps versus one long face-to-face encounter that's performed by a team versus a single provider whenever possible. So for example, a medical provider such as Sean is a nurse practitioner in a couple of the UNM school-based health centers, could find a student screening positive on the student health questionnaire and could therefore administer the indicated longer assessment instrument, the SCARED. And when that indicates a more comprehensive assessment for depression could be performed by Chris or Lisa, therapists working in school-based health centers.
So that the primary care provider has a role through the assessment.
That's right. The primary care provider would definitely have a role that we define as the screening and first step in the assessment.
Okay.
Now, just as a quick caveat, I'll mention that some places in the pediatric literature describe both of those roles as being part of the first and second screening steps. In our quality improvement behavioral health for initiatives for school-based health centers, we refer to these as screening and assessment respectively. Well, I mentioned that the SCARED is the anxiety assessment instrument that's used in many school-based health centers. It's a bit of a misnomer, actually, because it has the word screen as the S in SCARED, the acronym for Screen for Child Anxiety-Related Emotional Disorders. We also think of the S as connoting self-report, because the SCARED is a reliable and valid self-report instrument for childhood anxiety disorders in clinical settings, developed at the University of Pittsburgh's Western Psychiatric Institute and Clinics by Burmacher and others, dating over a decade ago. But it's subsequently been found to be reliable and valid. This self-report questionnaire measures symptoms of anxiety disorders, a la the DSM-IV, in children 9 to 18 years old, across 4 factors with 41 items that ask about the 5 domains, 5 factors of panic/somatic, generalized anxiety, separation anxiety, social phobia, and school phobia. It does not ask about domains of OCD and PTSD. It is scored for a total score and 5 subscores for the respective 5 factors. There are parent and child report versions, and Spanish version is available. Responses to the statements are rated on a 0 to 2 scale. And for anybody who's interested in seeing the SCARED, it's available in the public domain at this website at the University of Pittsburgh Department of Psychiatry. It also will be covered in the next webinar. So in our remaining several minutes, we can talk about at least one anxiety case example.
Okay.
Please, Chris, tell us about the student in the 10th grade.
You mean Sierra?
That's right.
Okay, she's a 10th grade student. She came to the school-based health center during first period, complaining of being short of breath and having a stomach ache. She appears distressed and says that she wants to go home. She has an exam during second periods. She's a good student. She's prepared for the exam but is worried about it. Her absence rate has increased dramatically over the past several weeks. She indicates that it's because of stomach aches, headaches, and being stressed out. And over the past few weeks, she has felt the ways she feels now a few times. Sometimes it gets so bad, quote, I feel like I'm going to die, unquote. When it gets that bad, she says that she gets sweaty, dizzy, and gets an upset stomach.
Well, there certainly is a lot going on with Sierra for a student who might otherwise appear like nothing's troubling her. So, what are common features of anxiety that Sierra is exhibiting?
Does anybody want to hazard a guess? Maybe we can go back to the previous slide. Anybody just chime in what you see in this example.
Sweaty.
Well, this is Cindy. She's having the headaches, the stomach aches. She's been missing school.
Okay.
Good points. And I think also mentioned was sweating.
Dizzy.
Mm-hmm.
What other symptoms would you ask about to identify an anxiety problem?
Well, once they were talking about having that sweating and being dizzy, shortness of breath, that almost sounds like she's going to start having a panic attack to me.
So what might you ask about that would correlate with the sensation or experience the student might be having at this time?
Rapid heart rate, muscle tension.
Especially the muscle tension. The rapid heart rate is certainly worth asking about. I think for the student it might be experienced more as the aspect known as palpitations, feeling their heart thumping in their chest, whereas the heart rate is something that's more of a sign that we would measure.
They also start talking about numbness and tingling in their, usually their hands or their arms, sometimes in their feet, but usually their hands and arms.
Good answers. Good points.
Definitely.
So, what kind of anxiety condition might this student have or not have?
Well, it could be a social performance anxiety.
It sure could be. Any other of the anxiety disorders that you might consider?
Could be panic disorder.
Sure could be. And it also could be a generalized anxiety disorder.
Because all of these are elements of that, the performance.
Especially since performance and social anxieties can and associated somatic complaints and school absences and excessive worries can all be characteristic of all of those. Should we?
I think we don't have time for
I think we should continue and keep the case here for your own consideration. And you would be welcome to bring questions and concerns up at this time.
So in the
Go ahead.
With the DSM-IV, is there any mention that you know of regarding tobacco use for stress reduction?
I don't know of it being described in the DSM-IV. But a widely used substance abuse screen in school-based health centers and other primary care settings is the CRAFT. And the R in the acronym CRAFT stands for relax, about substances in general. Do you use to relax? So I think it would fit with that screen, but I don't think it would fit with the DSM-IV criteria, which are more along the lines of compulsive use, continued use despite consequences, excessive craving, and attempts to cut down. Which, by the way, Ivan, brings up the whole notion of how youth substance abuse typically and dependence typically doesn't fit that scheme, which was really developed to describe degrees of substance use disorder in adults.
Sure.
You know, I had momentarily advanced to mentioning an interest in connecting with you again. We have more December offerings, which can include opportunities for further discussion about anxiety as well as depressive disorders. Our next school-based health center behavioral health quality improvement webinar, again, will be in just under 2 weeks on Monday, December 16th, which will further describe the SCARED and the PHQ-9 modified for teens as anxiety and depressive disorder assessment instruments for use in school-based health centers. And 2 days later, we'll have the School-Based Health Center Provider Case Conference Forum, which really encourages you to bring your cases of students seen in school-based health centers, especially presenting with anxiety and/or depressive disorder-like problems and their comorbidities. And it could also be a place to bring further questions from these webinars.
You bet. If you have a student that you're concerned about that is experiencing anxiety,
please, it would be a great time to talk about those students further. Another opportunity for individual case consultation is through the telepsychiatry consultation offered 4 afternoons a week, preferably through advanced scheduling with Clancy, and I can provide you consultation at that time. Resources are also included in your handouts, such as the following websites with the Child Psychiatry Academy, the Pediatrics Academy, Envision, New Mexico, and again, the website for obtaining the SCARED. Publications are also listed herein, including the DSM-IV. So at this point, I'd like to take roll call to ask who is still online. We've heard from Ivan. I think we were also hearing, was that you, Susan?
Yes, Susan is still here.
Catherine?
And this is... And this is Cindy Brault.
okay.
Thank you for participating. Cindy, anybody else?
Well, thank you for your participation.
Thank you from both of us. And thanks to Kevin, our IT support, who faithfully joins us in these webinars.
Our silent partner.
Thank you.
Bye-bye.
Have a great day. Thank you.
Bye.
Bye.